So it's my great pleasure to be always in Yoshid. I will try to follow the instructions and will be stick to the time and may try to save some slides. I don't want to have a lot of overlap, so my talk today was about endoscopic management of different esophageal lesion. The esophageal lesion may be mucosal, and I think we have the guidelines, and Hani show us some lesions, how we can do endoscopic resection for mucosal lesion. It's here a circumferential esophagogastric lesion. It still can be resected. Submucosal lesion, we can go for stair, but sometimes we have point of debates or difficulties like this lesion because it's located anterior and just be behind the cardiac pulsation. But actually, we still can go for stair in such lesions, but we should be little bit careful while trying to resect, because actually behind us is the pericardium, and we can see at certain point some pericardial pulsation. So we should be cautious, but still we can resect. This white pulsating structure behind is the heart, but it still can be resectable. Here, one of the cases I wanted to show, when we have a large submucosal lesion like this, it causing symptoms, and actually it's a lipoma. I wanted to show because sometimes we have some debates about best strategy. By US, it's originated from third layer, but sometimes you are not very sure. The large lesion make resection sometimes difficulties. So the best way in such lesions to cut the distal end and to cut the lateral margins, and then start to cut the proximal and push the lesion back, and depend on the size, the weight of the lesion, it will facilitate the resection. This is the best strategy to deal with such bulky lesion. If you didn't do this and try to tunnel such lesion, it will be very difficult, and actually you may injure the muscle. So the best way here that we did, we cut the distal, then we started to cut the lateral margin open totally. So when we push the lesion back, it's pushable. If it's attached to the side, it will not be easy to push to the back. Once we do this, it's very easy to dissect the center and use the cap to push the lesion and dissect it, push the lesion and dissect. And here we can see we use the near focus. It facilitates and differentiate between the structures. And by the end, in less than 1 hour, we can resect such lesion. And taking out a lipoma from upper esophageal sphincter is a little bit more easy because it's fleshy and compressible, and we can take it out. We can see here the resection bed, and this is the resected lesion. Again, submucosal lesion can be resected even if large like this. This is also a debatable case, again, for a submucosal lesion, a patient with GIST, but she do US FMB and she have a bleeding, significant bleeding. You can see here there is a hematoma in the lesion, and this was the lesion after 1 month. We can still see some nibbling here for the site of bleeding from the FMB. You can see here. So it was debatable, can we go for stair? We can expect some hematoma, some adhesions or not, but actually it's still possible. And we resect the lesion in block with intact capsule, and we have this surprise. We can see the hematoma inside the lesion here, but it didn't prevent to resect. And this was accepted in GIE. I think very soon we will see online how to treat a bleeding GIST by stair. Sometimes we have not a mucosal or some mucosal lesion, we have some rare lesion. It's very common in esophagus, or we see a lot here in Egypt. We don't have a lot of squamous cell cancer like this lesion. We can see this lesion in esophagus. Actually, it's an esophageal hemangioma. It still can be resected, and we publish our experience about such lesion for a case series of ESD for esophageal hemangioma, which is less invasive and more safe than surgery. And this is another case with another rare lesion. This presentation was prepared by my teammate, Dr. Ahmed Madkour. So we have a male patient with a dysphagia, and we can see here in the MRI image, we have a large defect. And when we do the initial assessment, we can see here, actually this is the tube, and this is the arytenoid cartilage, and we have a huge lesion originated from arytenoid and extend to the cardia. And we still can go for resection. We go for ESD. We started to do a mucosal incision. But the procedure was bloody. With every touch, you have a bleeding, severe arterial bleeding. And again, even you don't see any suspicious vessels here, just when you try to cut, you have a bleeding. But fortunately, we were able to finish the procedure. And we can see here the lesion stuck in the esophagus after we resect. And we push the lesion to the stomach. And here, when we are in stomach, when we go for retroflexion, we can see this huge lesion. And we take it out piecemeal, and that was the lesion. And the pathology was a giant fibrovascular polyp. And we can see here the remaining stump. We did a band ligation for it to prevent affecting of the airway. And we can see here the follow-up after 6 months. Actually, we just have a bulky arytenoid. The symptoms improved, and the patient didn't have a dysphagia at all. And this was a nice review for the published cases for the giant fibrovascular polyp and how it can be resected, either surgery or endoscopic. Sometimes this huge lesion need to do esophagectomy and gastrostomy to take it out. Sometimes patient, when he cough, he has the lesion out and they cut, but we still can do this endoscopically, as we see. The last case for some benign rare tumor is this lesion in a young female complaining of dysphagia. This is characteristic for granular cell tumor, and actually we did US, and it's originated from the third layer, and the biopsy was granular cell tumors. Usually in such lesion, it's originated from third layer, but you should give one possibility. It's originated more deep from fourth layer. So we learn to do a tunnel for those lesions. So if it's originated from fourth layer, it's a stair. If it's originated from a third layer, not fourth layer, we just open the tunnel. So we just do a tunnel and go out. We make sure we already pass the lesion. So then we can open the tunnel and take the lesion out. And I think here we can see this is the resection bed. Granular cell tumor is one of the rare tumor, but it's very common in esophagus, usually in lower esophagus. It can be resected according to the size by EMR or by ESD. So this was the presentation, and thank you.